Camille Harding. I'm with the Office of Behavioral Health. I think on the directory that I saw, I was listed as a PhD. I'm actually not. I am an LPC, so licensed professional counselor. So my background, I've practiced as a child and family therapist, primarily working with children involved with child welfare, victims of crime, and operated a private practice for about 15 years before I left private practice full-time and then went to work at the Mental Health Center of Denver, overseeing the child and family outpatient clinics, and then subsequently went to healthcare policy and financing, worked with Medicaid for a handful of years as the quality health improvement section manager, and then now I am the division director for behavioral health with the Office of Behavioral Health. So I've sort of come with both practice background as well as sort of payer and policy perspective. So I'm just going to go through a high-level overview of what the Office of Behavioral Health does, what we oversee, and then a little bit of background about the Behavioral Health Task Force that's currently underway that CDHS is operating, and then also our population and needs study that we're conducting. So we can go to the next slide. Sorry, I can't drive my own slide, so we don't need to go through the agenda. I can kind of walk through, and I tend to skip around and we'll just go to the next slide. And maybe the next one, sorry. So the Office of Behavioral Health oversees and regulates the behavioral health care system. So what that means is that we both license and designate behavioral health providers within the state that are not independently licensed by DORA. So the Division of Occupational and Regulatory Agencies oversees independent licenses. So LPC, LMFP, LCSW, etc. So we do facility licensure and oversight. We look at charts related to specific regulatory framework that's outlined in our section of statute. And then in partnership, we work with CDPHE, who does facility licensure as well. So the next piece is we pay for services for portions of services that are typically not covered by Medicaid, and we can kind of walk through what that looks like. And so the way that we do that is often through contracts with providers and different organizations that oversee networks of providers. The Office of Behavioral Health also does a lot of technical assistance, training, data analysis, and support to providers around the state in various areas. And then we also operate the 2 state mental health hospitals at Fort Logan and Pueblo. I'm mostly going to talk about the stuff that's in the community, but if someone has questions about the 2 state hospitals, I'm happy to answer that as well. So next slide. This is just sort of an overview slide of the different divisions. So I oversee the Community Behavioral Health Division, and then there's the Division of the Mental Health Institutes, which are Fort Logan and Pueblo state hospitals, and then we have a division that oversees our communications and policy work. That's sort of an umbrella to both sides of the house, if you will. Next slide. So within the Community Behavioral Health Division, we have a handful of different teams that work on different areas of focus. So our data and evaluation team collects data and does a lot of reporting around mental health and substance use utilization, as well as specific areas, and does a lot of evaluation work. And then we have a business and support services unit that does all of our contracting and our budget work. Then we have our licensing and designation team, which oversees our regulatory framework for the state. And then separately, we have our more program areas, which are adult treatment and recovery, criminal justice prevention, and children, youth, and family teams. And we'll walk through kind of what the scope of each of the things that they oversee as we get through the slide deck. So next slide. So I think kind of the way that helps to think about what we oversee in terms of our payment for services is really our major contracts. So we have contracts with all of the 17 community mental health centers around the state that oversee a variety of services that are paid for by Medicaid, the Office of Behavioral Health, and many commercial contracts as well. And by commercial contracts, I mean commercial insurance. So, right, like United, Cigna, Kaiser, et cetera. And then also within the community mental health landscape, we do a lot of payment for different evidence-based programs. So, for example, we monitor fidelity for assertive community treatment, which is a model that's intended to target folks that have serious mental illness, have a lot of psychosocial stressors and vulnerabilities such as homelessness, criminal justice involvement, et cetera. And it's an evidence-based model that improves outcomes for that population engaging in treatment and seeking services. So as an example, that we also do evidence-based program implementation and monitoring. And then we also pay for folks for services for individuals that maybe don't qualify for Medicaid, maybe underinsured, have a high deductible with their commercial plan and need services. And so we do have contracts with all the community mental health centers to offer that sort of safety net funding to ensure that folks have access to treatment. We have, oh, sorry, I was going to walk through the administrative, sorry, if you go back one more, yep. We have ASOs that oversee our crisis services, which we'll get into a little bit more, and then also managed service organizations that oversee a network of providers that do a variety of substance use specific treatment programs. And again, this is a place where the Office of Behavioral Health pays for services that fall outside of the Medicaid benefit and essentially covers individuals that may or may not have coverage for a particular set of services. So currently it's the residential and inpatient benefit with Medicaid for substance use services. Medicaid is currently working on bringing up and expanding that benefit, but in the state, we currently have the funding, the vast majority of funding to fund residential treatment for substance use via our managed service organizations. So if we go to the next slide. Will you yell at me if someone has questions, Erin, or if someone has something, you could certainly stop me and ask if you need.
Sure. Everyone is in listen only mode, but yeah, I'm monitoring the Q&A button, so people are encouraged to enter them throughout the presentation, and then we have, you know, a lot of time at the end to take those. So
okay, great.
Sure.
So as I mentioned, the Department of Human Services has taken on the Behavioral Health Task Force, which Governor Polis directed us to do to really evaluate our current behavioral health sort of system within the state and to develop a behavioral health blueprint by June. That blueprint is actually being delayed because of COVID. We've had to suspend for a bit of time our task force meetings in knowing that folks were tied up with COVID-related activities. So we have just resumed those meetings, and we anticipate the blueprint to be completed mid-August, which is our new deadline. And essentially, we are walking through in each of these subcommittees sort of current challenges, barriers to access to care, data collection, large payer and systemic changes in each of these subcommittees that will roll up to the larger task force and make recommendations about how to streamline and essentially improve upon our existing system. to make sure that we have broader access for all Coloradans. And so there are these different subcommittees that are currently operating to make recommendations about areas of opportunity and current sort of barriers in the system. So I am on the Children's Behavioral Health Subcommittee, and then we have different representation from all around the state in each of these other subcommittees. The other opportunity for individuals to weigh in on behavioral health services around the state is really Summer Gather-Cole, who was a special advisor to the Behavioral Health Task Force, has been traveling around the state for the last year, doing various convenings and public testimony from individuals that have had barriers or challenges accessing behavioral health services around the state. And so we have a pretty robust set of testimonies, and I believe there's still opportunities for individuals to weigh in on their personal experience, or as a provider or navigator in the system, where are there barriers and places that we need to be thinking about. So we have had, I want to say we have over 200, I don't know the exact number, of individual testimonies on behavioral health that are also part of the set of recommendations that I think are being rolled up into the task force. The one other area that we're sort of leveraging in addition to the testimonies and the subcommittee meetings and the overall task force is we're conducting, the Office of Behavioral Health is conducting a population and needs study. So what that means is that every several years, as part of our funding that we get from Substance Abuse Mental Health Services Administration, which is part of Health and Human Services at the federal level, requires that each state that receives this federal funding must conduct essentially a needs assessment to identify priorities within the system and where additional investments need to be made. And so in conjunction with the task force, the population and needs study is also underway. And we are, Health Management Associates is conducting our population and needs study, which we call the PIN study for short. And they have also been around the state, participated in some of the community convenings and public testimony, and have also done some surveys and is looking at all our publicly reported behavioral health data sets through leveraged in the overall sort of set of recommendations.
Sorry about that, everyone. I'll get the slideshow back up. Sorry, Camille.
No worries.
Little bit of technical difficulties today.
I can download my own slide deck, so that's why you're driving.
All right, next slide.
Yes, please. We can go to the next slide. So as I mentioned, the Office of Behavioral Health has a licensing and designation team that oversees the regulatory frameworks for mental health and substance use providers in the system. So we license and designate DUI providers, substance use treatment providers, opiate treatment programs, community mental health centers, and several other sort of providers within the behavioral health landscape. Also, in addition to that, there is something that we tend to get lots of questions about, which is 2765. 2765 is the law that secures care and treatment for individuals with mental health needs. So these are mental health holds. This is a section of our regulation that speaks to 72-hour holds when someone needs to be placed on a hold due to safety for themselves or someone else. And also the other section is gravely disabled. So 2765 is sort of the regulatory framework that defines how behavioral health services have to be provided and all the sort of protections for the individual being placed on a hold, as well as facility requirements for being designated as a 2765 facilities. we can move on to the next slide. So this is just more regulation and rule. If you're interested, you can go read through these sections of rule, and it talks about our holds, the M form that I think people may be familiar with, and the procedural manual. We can go to the next slide. And so about 2 years ago, there was something called the 0.5 hold that allows law enforcement to place a hold on someone that may be experiencing behavioral health crisis. This essentially is a transportation hold and allows law enforcement to transport individuals to a behavioral health facility, such as a crisis stabilization facility. We have a lot of walk-in centers established around the state, as well as community mental health centers and other providers around the state that are designated as 2765. So oftentimes this is an emergency room, but it allows an intervening professional, if they're uncertain about whether someone meets the full criteria for placing a hold, to at least do a transportation hold and get that individual to a behavioral health provider to have a full evaluation. So this is just another section of rule that outlines procedures for individuals in behavioral health emergencies. We can go to the next slide. Let's see, were there any questions? It looks like there might be. No. Is the 72-hour hold still in effect today? Okay, so I'm seeing a couple of the questions. I'll just answer. The 72-hour hold, yes, that still is in effect. So it's referenced in lots of different ways. 2765 is the section of rule that oversees what can happen procedurally for a 72-hour hold. But essentially, if someone is deemed to be at risk to themselves, others, or gravely disabled, a provider with that's outlined in rule, so LPC, someone with a license to practice within the state, physician, etc., can essentially place a 72-hour hold, and that person can be held for that period of time. And then there's other procedures that have to happen if they're going to be held longer than that. But a 72-hour hold is still in effect today. And then there was a question about budget cuts that Governor Polis spoke about last week. So we are still monitoring the budget. The Joint Budget Committee and the Office of State Planning and Budget are working really closely with us on our budgets, and we expect the final budget to be out the end of May. So we'll have more information as soon as that is finalized. Okay. So the next sort of section is our child and family team that oversees a variety of programs and activities around the state. So one of the big pieces of legislation that happened last session was Senate Bill 19195. And this is essentially a bill that establishes some centralized function for screening, assessment, and a single entry point for children and families. So this bill is in partnership with Healthcare Policy and Financing, and some of the work is being undertaken in the Behavioral Health Task Force and the Children's Subcommittee. So one of the things that was recommended is that the state pursue standardized single entry point, that anyone that might have a kiddo or identifies a child or family that has behavioral health treatment needs can refer that child or family to a centralized place, who then can subsequently do an assessment and help make recommendations about what the set of services would be that would meet that child and family's needs. So the task force, the subcommittee, children's subcommittee of the task force, is making recommendations and deliberating about what that should look like. And we expect those recommendations to be out with the blueprint in August. The other piece of this is that it requires Healthcare Policy and Financing to develop a payment model for paying for high fidelity wraparound services and care coordination for children and youth enrolled in Medicaid who may be at risk for out-of-home placement. And then it also requires the Office of Behavioral Health to develop essentially the infrastructure, standardize the assessment, and work with communities around establishing the teams that would be doing the high fidelity wraparound services and the technical assistance for those entities around the state. So that's what Senate Bill 19-195 is. It's intended to reduce fragmentation and centralize some of the single resources for children, youth, and families that struggle with accessing services. The one other area that the Senate Bill 195 calls out is screening. So statewide screening, it was recommended the Office of Behavioral Health do some work to standardize the set of screening tools that should be conducted in partnership with providers around the state. So we are working with the Colorado Health Institute, Colorado Pediatric CCHAP, I've forgotten what it stands for, and a lot of pediatricians around the state to walk through our existing framework for screening and primary care for children and youth and their families. And so that work is underway as well, and we expect there to essentially be a compendium of tools that should be used across the lifespan for children, youth, and families for screening kids in primary care, and then subsequently leveraging those resources to identify kids that may need to be referred to the single entry point. So if any of you are interested in participating in that work, you can certainly reach out and I can get you added to the Senate Bill 195 Children's Subcommittee or Children's Screening Tool group that is working on making recommendations. And so far they've narrowed it to about 25 different screening tools that pediatricians and primary care providers are using around the state. Okay, so next slide. So again, the Child, Youth, and Family team does a lot of technical assistance and capacity building with providers around the state. A couple of programs that we oversee are the Healthy Transitions Program, which is a program for transition age youth who may be experiencing homelessness. And we partner with different providers in communities to implement that program. Ascent, which is our first episode psychosis program, which again is for transition age youth who maybe have their first episode of psychosis. And it's an evidence-based family model to intervene with youth that have experienced their first psychotic episode. So those two programs are examples of some of the technical assistance and capacity building that the Child, Youth, and Family team does around the state. The one other thing that's listed on here is the Child Youth Mental Health Treatment Act. So the CYMHTA for short, which just rolls off the tongue, is the program that essentially enables children, families to access a set of resources that the legislature has set aside to deliver services that might not be covered under a commercial plan. So this Child Youth Mental Treatment Act is really for kids that are commercially insured and was created in, I want to say the early 2000s as a way to keep kiddos that maybe don't need to be in out-of-home placement in their homes and with their families and provide them with the right set of services and resources. So this program will do an assessment with a child, make a set of recommendations about other interventions that might be helpful beyond sort of your routine course of care. So CYMHTA oftentimes put together packages of services for children that have high behavioral health needs that would maybe benefit from mentoring programs, outdoor education programs, and also sometimes residential treatment. So CYMHTA pays for a variety of services, and the way to essentially request a CYMHTA evaluation is to, we have on our website, a location that is the Children, Youth, and Mental Health Treatment Act, and they can get you in connection with a provider in communities that can do an assessment on a child and family, and help put together a set of services for kids that might need a variety of other wraparound services that are traditionally covered under a commercial plan. Next slide. And this looks like we can skip through this one. I already kind of talked about the Ascent program, but it does list some of the community mental health centers around the state that currently offer the Ascent program, and gives a little bit more information about what that model is. The next slide. And then again, the transition age youth programs, and the Healthy Transitions Grant in partnership with Urban Peak that does mental health and substance use treatment, as well as outreach to youth who are homeless or at risk of homelessness, in both the Denver metro and Colorado Springs area. Next slide. And then here's another slide on the Child, Youth, and Mental Health Treatment Act. I think you'll get copies of this, and it has more specific information as well as how to access the website where you can go to refer a child or family to the program if they're not getting the right set of services via just traditional outpatient services or need additional support accessing the right set of services. Okay, so the next one is our adult treatment and recovery team. You can go to the next slide. So this team, before I talk about the opiate grant, this team oversees a whole host of programs that spans a variety of treatment locations around the state, including community mental health centers, substance use treatment providers, as well as some other specialty contractors that oversee a variety of services. So the first one that I'm going to walk through is just the opiate grants. So the Substance Abuse Mental Health Services Administration, in response to the opiate crisis, has provided the state and every state around the nation with additional funding to support intervention and treatment for the opiate crisis. So the Office of Behavioral Health in 2017 received $15 million, over $15 million. In 2018, $38 million, and then this upcoming September we'll receive another $20 million, and these are 2-year programs to support treatment services for individuals experiencing opiate crisis or opiate treatment needs. So this just walks through the variety of ways that we've implemented our additional resources around the state. So we've implemented the CRAFT model, which is a model that's really intended to be delivered to families that may have someone using substances in their family system. And it's really a model intended to help that family cope with the stressors for themselves, as well as support the individual as they enter into treatment. We've also done a lot of work with the Colorado Hospital Association and providers around the state that are in the primary care space to train physicians both on opiate treatment models, specifically buprenorphine in primary care, as well as alternatives to opiates for individuals that may have some other medical condition. We've used the funding to expand medication-assisted treatment, mobile medication-assisted treatment vans in rural communities, and those mobile units have just started rolling back in January, and we have a map that is on our website if you're wondering where those MAT vans are going and which communities, but they do stop once a week and are a way for folks that don't have a lot of access points for medication-assisted treatment in rural communities to connect folks to treatment services that may need them. And then, as I mentioned, we've done a lot of work around buprenorphine training for prescribers. So what that means is that a primary care provider can prescribe buprenorphine to someone in a primary care practice for assistance in treating their opiate treatment needs, and also have done a lot of technical assistance with primary care practices to help support them in treating individuals with substance use disorders in the primary care setting. We've additionally done a lot of work around criminal justice, day of release, community-based referrals to medication-assisted treatment, law enforcement education. We've done a lot of work with peer coaches in the workforce, employment services. So there's a model called IPS, it's Supported Employment Model for individuals with mental health or treatment, substance use treatment needs, and have done a lot of pilots for employment services, or 3 pilots, I think, for employment services in the substance use space that have historically been located at our mental health centers. And then peer-run sober living funding. And then naloxone education and distribution. So next slide. If I'm not hitting the right sort of level of information, feel free to stop me. So we can skip through this. I already kind of talked about some of the grant funding and emergency room inductions is one of the pilots that we did in partnership with the Hospital Association. We can skip through that slide as well. And then I did talk about altos. So this is pilot in 10 inpatient hospitals around the state that is intended to reduce opiate use and for individuals that maybe had been hospitalized for a condition and also any sort of medical condition, but also had been experiencing or been using opiates for pain or other sort of issues, that you can do alternatives in the inpatient unit to opiate treatment as a way to sort of reduce risk of addiction to opiate treatment. And so this was a pilot that we conducted with the Hospital Association. Next slide. Okay, so this next slide is called the Transition Specialist Program. So this program is operated, this program, in addition to one other program that's called Momentum, is operated by Rocky Mountain Human Services. And essentially this program is intended to support individuals that maybe have a lot of emergency room utilization or withdrawal management utilization. So detoxes, emergency rooms, and other sort of crisis services around the state. And really work to engage those individuals and connect them to treatment. This program also has flexible funding attached to it. So the case managers and peer bridgers that operate this program will connect with someone after her referral from an emergency room or some other provider around the state and say, like, we've seen this patient a few times. We're wondering if we can get them connected with a peer bridger. The peer bridgers will do some engagement activities, really help identify what that individual needs, and then hopefully put together a set of services that will help connect that person to ongoing treatment services. Again, this program has flexible resources, so that means that there is some ability to connect folks to housing. There are housing vouchers tied to this program. This program oftentimes will pay for different things like transportation, support looking for employment, connection to supportive employment programming, connection to treatment, and does a lot of sort of placement work as well in terms of housing and resources. So next slide. This is just some additional criteria around the transition specialist program. So you can read through that if you're interested, and it can walk you through sort of the criteria and how you might get a client connected to this program that you think might be an appropriate fit. So next one. Nope, it just gives you a referral. And then the next slide. So this slide also is operated by Rocky Mountain Human Services, so the same sort of organization oversees this program. And this program is really to help discharge patients into the community from a hospital level of care. So it originally started out as a way to transition patients out of the state hospital back out into the community who had lots of barriers to placement in the community. This program works to find skilled nursing facilities, assisted living programs, host homes, and other housing options for individuals that maybe need supports living in the community, but no longer need to be in our state hospitals. And we've since expanded this program, and we work with a lot of psychiatric hospitals around the state that maybe have patients that have had long lengths of stay or multiple lengths of stay or multiple 72-hour holds over the course of a short period of time, and struggle to get connected to the right set of services in the community. So this program will connect them with a case manager and put together the right set of services for these individuals. Sometimes, again, this is a program that has flexible funding attached to it, and so they pay for a variety of services. In some cases, we've had a patient identify that they felt like they would be more successful if they had a therapy dog and worked as they were preparing for transition with the therapy animal so that they could be successful in the community. Sometimes these are folks that have lived in the state hospital for 2 to 3 years, sometimes longer, because they were found not guilty by reason of insanity or incompetent to proceed, and have had relatively long lengths of stay in the state hospital and are ready to transition back to the community and just need a lot of wraparound supports to be able to do that successfully. So that's what this program is intended for. But both of those programs, the Transition Specialist Program and Momentum, are operated by Rocky Mountain Human Services. So next slide. So I believe that I briefly mentioned ACT, which is a treatment model at the beginning of my presentation, but ACT is one of those programs that we do fidelity monitoring for. It's an evidence-based model that all of our community mental health centers operate around the state. And it's really intended for folks that have serious mental illness that maybe have had a history of repeated psychiatric hospitalizations and have not responded to traditional sort of interventions. This model is really intended to be a lot of engagement and outreach to populations that might have a lot of risk factors and vulnerabilities that may increase the likelihood that they don't connect to normal treatment. And so it really is assertive community outreach. And so there's a lot of teams that work with these patients to get them connected to services. So it includes both medications, case management, crisis services, employment, and then supports that include helping the individual participate in normal activities of daily living. And this gives you a list of the community mental health centers that operate these programs. So next slide. And then I think I briefly mentioned managed service organizations. So our managed service organizations are essentially the entity around the state that oversees the substance use services and the network of providers that are funded by the Office of Behavioral Health. And so you'll see on this slide, it walks you sort of the list of the services, all the way from outpatient treatment to residential treatment, prevention programs, and specific programs that are targeted towards particular populations, including criminal justice, or women's treatment services around the state. And then the next slide, I think, is a map. Yep. So this is a map of our managed service organizations. If you, in a list of the names of the managed service organizations that oversee each of the regions, so they administer all the dollars that the Office of Behavioral Health has for substance use treatment, are administered through the MSO, and then they pay the network of providers and oversee the resources for substance use treatment around the state. And again, you can go to our CDHS website, has specific contact information for each of the MSOs that we oversee. Let's see, I'm gonna just check the questions before I go on to the next thing. Okay, looks like there are not any others. Okay, so next slide is Colorado Crisis Services. We can go to the next slide. So the Office of Behavioral Health oversees the Colorado Crisis System, which is comprised of a few different components. This lists our budget, which is about $30 million. In addition, we have, that's not included in this, is our state hotline and some additional federal funds that we've used to support the crisis system. So altogether, our crisis system that is operated out of the Office of Behavioral Health is about $35 million investment from state and federal funds. We can go to the next slide. We can go to the next slide as well, unless anyone has any questions. So this essentially is a map of our administrative service organizations. So last year, the state of Colorado was required to re-procure services every 5 years for contracts. And the Colorado Crisis System that was originally funded after the 2014 Aurora Theater shootings allowed Colorado to implement the first iteration of the crisis system. The first iteration of the crisis system had about $21 million. And since then, the legislature has made additional investments in the crisis system. And the crisis system is really intended to deliver 4 different services. And in overseeing these services, when the state re-procured the crisis contracts this last summer, we decided to align the crisis system with the Medicaid RAY regions in an effort to hopefully mitigate some of the confusion, align payment, data collection, and also providers not having different geographic regions that they have to maintain in their head. And so this is just a map of where each of those regions are and who oversees the crisis dollars in each of these regions. So in some cases, in the example of Rocky Mountain Health Plans, Region 1, they are both the RAY region for Colorado Medicaid, and they are also the administrative service organization for the crisis system. And in some areas, right, like the metro area, Signal Behavioral Health oversees regions 3, 5, and 6. And they are not a RAY contractor, but they oversee the crisis services for the metro area and work really closely with the RAYs. Coincidentally, Signal Behavioral Health also is a managed service organization that oversees our substance use services. So you can just kind of see the map, the geographic map of those ASOs. So next slide. One of the major key changes that was made in the crisis system when the system was re-procured was to prioritize mobile response. So we've really done a lot of additional work in building up that infrastructure and recently completed training with many of the mobile crisis providers to ensure that there was consistent and standard crisis risk assessments being conducted with patients when they were encountered in communities by a mobile team or came to a walk-in. And so we think that that's really going to go a long way in standardizing some of the risk assessments that are being conducted by the crisis system providers around the state. We also have put in a ton of additional requirements to try and encourage community-based response, including really thinking critically about who needs law enforcement to be on scene for a mobile response and who doesn't. Are there instances in which it's totally fine for an individual to go out by themselves? We think that when a mobile provider is responding to a primary care practice, for example, you probably don't need 2 providers to go out. In that case, you're going to a home, maybe you take 2 clinicians, or maybe you take 1 clinician and a case manager, or there's ways to think about case managers going out in a pair and leverage telehealth as necessary. And then in some cases, we have co-responder teams that are part of our crisis system as well. So we can go to the next slide. So one of the other things that wasn't on the slide deck is our crisis hotline. So Colorado Crisis Services operates the crisis hotline. The crisis hotline is 844-493-TALK. The hotline is sort of the centralized location that if you're struggling with identifying the right set of services, or if a patient needs to talk to a clinician to help get a mobile team deployed, the crisis hotline is really the centralized place for individuals to call. And so that number again is 844-493-TALK. Hotline is operated by Rocky Mountain Crisis Partners. And Rocky Mountain Crisis Partners has over 100 staff that operate the crisis hotline 24/7, 7 days a week. They do a lot of really standardized training with those individuals that are answering the calls. And they also have both a warm line and a hotline. The warm line operates from 7 a.m. to midnight, and it's really for individuals who are interested in speaking with someone with lived experience. And so if someone just needs support, we do have a lot of individuals that are familiar voices that use that hotline, or warm line rather, on a fairly regular basis, just for sort of intermittent support. And then there's the hotline subsequently that any Coloradan can use at any time, free of charge, to get support and or get connected if there's any level of risk. The hotline clinician will do an assessment and then deploy one of our mobile teams that are located around the state. And so altogether, oh gosh, I don't have the exact number of mobile teams, but we do have mobile teams located geographically around the state, and the requirement is that in the metro area, the mobile team is able to deploy and be to an individual's location within an hour. And then in rural communities, there is a 2-hour timeline for the mobile team to be on scene to do an assessment with an individual. From there, the mobile team will do an assessment and make a determination about whether that individual has received sort of the intervention that they needed, they've safety planned, and have determined next steps, whether it be to follow up with an ongoing clinician or maybe get connected to an ongoing provider. And in some cases, if the clinician on scene, the mobile team determines that that individual needs to go to a higher level of care. We do have crisis stabilization units that were funded as part of the crisis system, where an individual may be placed in a CSU for a period of time, placed on a hold, a 72-hour hold, and then the crisis system from there is responsible for doing follow-up with those patients to make sure that they get connected with the right set of services. Any questions about the crisis system? No? Okay. So next slide is criminal justice. So our criminal justice team oversees a variety of services, including our co-responder teams, DUI services, jail-based behavioral health services, law enforcement assisted diversion, medication consistency, and some of our other specialty offender behavioral health services and residential substance use treatment programs around the state. We can go to the next slide. So jail-based behavioral health services, essentially that we have a variety of funding streams. We can go to the next slide that support jails with funding and technical assistance for implementing substance use, mental health, and other services in a jail. So next slide. This program was originated in, I believe, 2012, and provided funding specifically for substance use treatment in jails. And then since then, we just continued to increase that budget, and most recently, Senate Bill 18250 provided additional resources for mental health treatment in jails. And so we have contracts to help support local county jails with getting individuals who are booked into jail the right set of services. So one of the major things that we are undertaking this year is that as the funding for substance use, mental health, medication-assisted treatment, technology, medication formularies has been layered in over the last sort of decade for jails. We've arrived at a place where the jails are really struggling to figure out how to do the right set of services and really oversee these multiple contracts. And so we have contracted with the Department of Family Medicine at CU, and they are doing a lot of technical assistance with our jails to help them identify what's a standard set of screening tools you should do when an individual's booked in. What does your workflow need to look like? How do you get an electronic health record if you don't have one? How do I know what medication a patient might have been on before they got booked into jail? So we're equipping them with access to the HIEs, the health information exchanges, so they can query in and look at a patient's record and see, right, for example, this individual was prescribed metformin, they have a diagnosis of diabetes, and they're also on Seroquel. Rather than having to phone around and do paper faxing, they can have access to that information and then hopefully come up with a treatment plan, get the individuals the standard medication that they have been prescribed in the community rather than changing medications, and then also work on their case management needs and get them transitioned out and connected to the right set of services in the community. And so we're really trying to work with them on workflows, technical assistance, like workforce, all of those sorts of things. How do you use telehealth? And so the university is helping us with our jail-based behavioral health services in coordination back to community providers and identifying who those providers are that are willing to serve these individuals in the community. So we're doing a lot of work with our jail-based programs. So next slide. Sorry, I'm talking to my daughter. She wants help with math.
No.
I'll have to do it in a minute. We can go to the next slide. So this just talks about the funding that was layered in for Senate Bill 18250, which I mentioned. And then here's all the counties, and it just shows some of the existing programs around the state. And we are really working with all of our counties to identify if they don't currently have funding, how can we help get them funding to, and some technical assistance so that individuals that are being booked in are getting the right interventions. So next slide. Yeah, we can skip this slide. It just shows a breakdown of the different work. And then co-responders. So again, we received additional funding from Marijuana Tax Cash Fund to distribute these resources for co-responder teams. So altogether, the Office of Behavioral Health has over 40 locations where we have co-responder teams operating around the state. So these are intended to be diversion programs to keep individuals out of jails or other criminal justice involvement, and have a behavioral health provider along with a law enforcement trained individual to intervene in mental health or substance use related emergencies. And so this just shows some of the additional funding where these co-responder resources went. And then if we go to the next slide, I believe there's a, nope, sorry, this talks about program goals, but the next slide, I believe, nope, it talks about, sorry, this is program configuration. So we can have different types of teams that are considered co-responder around the state who have a variety of duties and responsibilities. But the next slide should, and hopefully it's the next slide, has a map of all the co-responder programs that are operating out of the Office of Behavioral Health around the state. And this just walks through the design of the program. There we go, there's my map. Yeah, so these co-responder programs are operated by our criminal justice team, and we really work on standardizing data collection, the evidence, the way that the program is designed so that we can evaluate some good outcomes related to the program. And in some cases, some of these programs are also partners in our crisis system. So if someone needs law enforcement response, but we also want to ensure that there's a behavioral health provider on board. In some cases, we do have co-responders that are participating in our crisis system. Okay, so I think that is all the high-level presentation of the majority of major program areas that we oversee within the Office of Behavioral Health. The one other thing I would mention is prevention. We do have prevention programs that are operated within the Office of Behavioral Health. Are prevention programs that are not reflected on this slide deck. We're just re-procured, and the awards are going out into communities, or should have already gone out to communities. And these are really substance use prevention programs around the state for youth, and intended to build protective factors for youth and reduce risk factors. And we did a lot of work with the Colorado Health Institute over the last year and a half to really identify resources and barriers in alignment with the Colorado Department of Public Health and Environment, who also oversees a variety of prevention, so that we have better alignment. So those are other funding that the Office of Behavioral Health really uses to target prevention activities for adolescents around substance use. Okay, so questions.
Camille, great. Thank you so much for this great information. And I think to all the parents and everyone who are multitasking out there too, thank you for doing that. So I know there's a lot going on for everyone. So just want to acknowledge that, and thanks a ton, Camille, for taking the time. I think most of the questions that have come through, the couple through the chat, have been answered. We'll go ahead and keep that line open. We'll give some time for people to even perhaps come off mute if you are on the phone. But Camille, one of my questions right now, I guess, given the state deficit and what we know coming in with the cuts in general and some of the other legislation, do you have a sense for what, and I think there was something about the cuts with POLIS and the like, but do you even have an idea if you'll be able to float additional legislation with some of the bills that are coming now, or what that status looks like for them to even pass this fiscal year?
Yeah, I mean, I think that everyone's doing a lot of quick work to see what can continue to move forward, and also ensure that the budget is balanced. And so we're also waiting to see what that budget is going to look like. But in the meantime, we do have federal funds that we use to pay for a lot of our mental health and substance use treatment programs as well. And so we're really just trying to monitor that so we can ensure that there are core services that are still operational around the state, and prioritizing crisis services, our residential substance use, and our community mental health center services to ensure that there's access. So I think we're also looking forward to see what the final budget looks like, and then we'll just kind of go from there.
Yeah, that sounds good, but it sounds like there's a lot of federal support that's already been in the budget this year, so hopefully that infrastructure will remain. I think it's always, I found it entertaining yet frightening and very scary when they referred to Governor Polis really looking in the cushions of the couches right now trying to find money. So I figure that's a little what it kind of feels like, finding some loose change and trying to pay your bills that way. So I think it's a lot, there's a lot of public health interventions this time that were on the ballot. So hopefully they find a way to make it through.
Yeah.
Yeah. Fingers crossed. One of the questions that I did receive right now is specifically for the utilization of services and the line right now. Have you seen an increase in people utilizing, because of COVID, relief or help in terms of mental and behavioral health needs or anxiety? Is there any sort of trends that you've seen different since the pandemic and shelter in place type activities have gone into effect?
Mm-hmm. Yeah, so our crisis hotline, who typically around this time of year will get about 13,000 calls a month, has seen a pretty sharp increase, and they're up to about 20,000 calls a month. So I think that certainly there's an increased anxiety and sense of isolation. So we're seeing a lot of additional crisis hotline utilization. Additionally, all of our providers that we work with around the state, we've seen them really have to pivot really quickly and think about how they can modify their service delivery. So a lot of those folks have gone to telehealth service delivery for folks that can benefit from that type of care. Separately, we've been working with the Colorado Department of Public Health and Environment and thinking about bed capacity, and are working on, in partnership with them, to think about transitions of care. So if someone doesn't need to be in an inpatient psychiatric stay, how do we help transition them to the right set of services and ensure that that they have a place to go? And so we're working on that in our crisis system, and did receive an additional $2 million in funding from our partners at SAMHSA to work on bed capacity for patients with mental health or substance use treatment needs, who may be COVID positive or presumptive positive. And then a lot of our providers have been thinking about really innovative ways to outreach their clients and engage them in treatment. So I think I just spoke to one of our providers that operates one of our first episode psychosis, so our transition aged youth programs. We're actually seeing more engagement from our first episode psychosis youth than when they are typically required to come into the clinic or come to a group at an office. They have a lot more engagement in via telehealth, which is interesting. So we're seeing that for our transition age youth, is that in some of our programs, they're more engaged than they would have been historically. And then I think the reverse is true with some of our adults with serious mental illness. They're less likely to engage, and right, even with multiple intents to outreach and engage them, we're seeing maybe not as much interest to engage via telehealth. So I think it sort of depends. And then our residential treatment providers, I think, have really done a good job of really thinking about what are the protocols that they need to implement to ensure that they're still able to accept patients, but they probably have done a lot of reduction in census, so fewer patients in a program, lots of hand washing, masks, temperature taking, and those types of protocols have been implemented. And everyone, I think, has just really had to think on their feet, pivot quickly, read a lot of CDC guidance, and partner with CDPHE to really think about how to continue delivering services in a safe way. And so, yeah, lots of additional work that's happening on our providers, around the state.
Yeah, it is. And I think, I think of the upshot, as you're talking about that utilization in telehealth and seeing that work, who's being here to say that it's really difficult for people who seem to be having the hardest time not utilizing those services. So there is a specific question that came in as we were talking that was specifically for Grand County. And are there any plans to include Grand County in the jail? Just because that makes sense.
Yeah.
Okay.
So actually, we've been outreaching all of our jails. In some cases, our jails have felt like that the contract work was too overwhelming for them to oversee, or in some cases, they have they've had to they've centralized some of the work, and so in some cases, some of our jails have partnered with other counties to centralize the resource. And so I think if you look at the map, I don't think that my map has been updated in the last several weeks. But one of the things that they're doing is trying to break up some of the catchment areas that have historically, I think, where they intended to consolidate resources and stretch them across a variety of counties. We're at a place where we have enough of a budget that each county can operate and design their own set of services at this point. And so we're really outreaching all those jails and saying, hey, that's probably what you did to manage resources 3 years ago, but in this current environment, we really want to work with you to make sure that you have the right set of services and are really thinking about your patient population and you're prioritizing those folks that have high psychiatric needs. And so we're working with and outreaching all those jails. So if you have a jail that maybe doesn't have services or doesn't know how to access services, again, right, they can reach out to us at the Office of Behavioral Health, and we are doing a ton of work with all the jails to really redesign their service delivery in their jails and make sure that they have the right set of services for individuals that are being booked in.
Wonderful. Thank you for that question, and thanks for the thorough response. Great. Thank you so much, Camille, everyone, and have a great afternoon. Thank you.
Yeah, thanks. Thanks for having me, and thanks for driving, Erin.
Sure. Thank you.
Bye.
Bye-bye. Take care, everybody.